Part 3 of the urinary system lectures. I'm going to talk about dilute and concentrated urine and the significance of that. And then I'm going to wrap up these urinary system lectures by talking about some of the diseases in the urinary system. We know that during the day, our fluid intake varies, is very variable. However, our total body volume stays stable. And that is very important because maintenance of body fluid composition and the volume is important for our cells to function normally. And the kidneys are responsible in maintaining the fluid volume in the body and the fluid composition, the osmolarity in that of fluid. It should stay in homeostasis. That's what we call it, fluid homeostasis. That the volume and the composition should stay within specific limits despite the variable fluid intake during the day. So the regulation of fluid osmolarity, or the composition or the concentration of the solids inside the solvent, which is the water, is the function of the nephrons. We know that the urine is made up of 95% water and 5% solids. The solids are the some of the sodium, potassium, calcium, nitrogenous wastes. So these are all solids that are 5% of the urine, and 95% is water. So the urine regulates also the body's fluid osmolarity by either keeping more water, reabsorbing more water, and make the urine concentrated, or bringing more water from the body into the tubules and making the urine more diluted. And that is the function of nephron. But the nephrons can't do this alone. They do it by the antidiuretic hormone, ADH. Antidiuretic. Diuresis means to urinate or to form urine. Antidiuretic. So when there is antidiuretic hormone, then the urine will be concentrated because antidiuretic hormone keeps the water, conserves the water, reabsorbs the water back from the tubules into the blood. But if antidiuretic hormone is absent, then the urine will be diluted. So this is the main concept that you have to keep in mind: the antidiuretic hormone and its functions. So in normal individuals, healthy individuals, when the kidneys are functioning normally, the amount, the urine output, which is from 1 liter to 1.8 liters, depends on how much volume, the fluid volume in the body, what's in that fluid, the composition of that, the osmolarity, and also the amount of the antidiuretic hormone. So if you drink too much water, then of course uh, the urine will be diluted and of high volume, because your body will try to eliminate excess water, because we want to keep the volume and the composition within specific limits. That's fluid homeostasis. But if you are drinking less fluid or you are losing fluid, then the urine will be concentrated. Means that you have more solvents than the water, because the body conserves water when in need. And again, that is the function of antidiuretic hormone. So making concentrated urine means that the body is conserving water. And how do we test that? By a very important test that we talked in the lab lecture too. It's about the specific gravity of the urine. The specific gravity test, it tests the ability of the kidneys, how they, if the kidneys are able to concentrate urine, if the nephrons are able to concentrate urine. So high specific gravity means concentrated urine, and low specific gravity means diluted urine. So specific gravity is the relative weight of a specific volume of liquid compared with an equal volume of distilled water. The specific gravity of water, distilled water without any ions in it, is 1, because 1 milliliter of water weighs 1 gram. However, urine is not pure water. The urine has has particles in it. The urine has dissolved solids in it. So that's why it weighs more than water. So its specific gravity ranges from 1.001 to 1.03. It depends. So here we can see the specific gravity of the urine. It's 1.00. It differs from book to book. In the lab book, it's 1.001, but here it's 1.003 if it's the urine dilute, and it's until it's 1.030. Okay. It depends how much solids are in the fluid. So if the urine is diluted and minimally concentrated, then its specific gravity is low. And if it has too much solid in it, it means that the water concentration is less, then the specific gravity is high. And this is the range between here and here. Below 1.003, if it approaches to 1, so it means that it's almost like distilled water. So the urine or the kidneys are not doing their job in excreting wastes. And if it is too concentrated, it means that the urine or the kidneys are producing too much waste. Maybe they are excreting more than the regular amount of sodium, or maybe the amount of water is less. Maybe the water is being reabsorbed back in larger quantities so that the urine is getting concentrated. So this urine specific gravity tells a lot about the functioning of the kidneys. So let's put things into perspective here, that the osmolarity of blood, which is very important for the cells to function normally, it is 300 milliosmol per liter. Okay? So in diluted urine, it's 50 to 70 milliosmol. In concentrated urine, is 1200 to 1400. So the body strives to keep its osmolarity always at 300 milliosmol per liter, both in blood and in the extracellular fluid. So who maintains that? Who regulates that? The kidneys. So when the kidneys detect that there is too much of solids in the extracellular fluid or in the blood, too much sodium, too much waste, nitrogenous waste, so it excretes them. And along with them, when it excretes them, it reduces the osmolarity in the blood. Or the kidney detects that the amount of water is less in the blood or in the extracellular fluid, and that's why the osmolarity is high. So the kidney, along with the antidiuretic hormone, reabsorbs more water, so the urine will be concentrated. However, that reabsorbed water will go back into the blood and keep the blood osmolarity at 300 milliosmol per liter. And that happens throughout the day just to keep the osmolarity of blood and the volume of blood and extracellular fluid constant within certain limits. So here, when we say dilute urine and concentrated urine, so dilute urine is that when there is excess water in the body and body fluid osmolarity is reduced, means it's lower than 300. So the kidneys excrete urine with osmolarity is as low as 50, between 50 to 70, and keep the sodium and keep the other elements inside to increase the osmolarity in the extracellular fluid, so that the osmolarity will stay normal in the extracellular fluid. So it will excrete excess water and keep the other elements to keep the osmolarity constant. However, with concentrated urine, this is the body's way to conserve water. So when there is a deficit of water and extracellular fluid osmolarity is high, it means that there is less water, and that makes the osmolarity high because in this case the solids percentage will be higher in water, so the osmolarity will be high. So the kidneys will excrete urine which is very concentrated. Means that the amount of fluid is much less in the kidneys, and they are reabsorbed from the tubules in higher amounts. Okay. It's almost 5 times the osmolarity. See here, if it's 300, the concentration will be almost 300 times 5, it's 1500. So it's almost can be as 5 times more concentrated. And that's why concentrated urine is darker in color. So the important concept here is that the kidney, if it's functioning normally, can excrete large volumes of dilute urines or small volumes of concentrated urines. That is the bottom line. And the important thing here is that the antidiuretic hormone comes into play. Of course, there is another factor too in formation of concentrated urine. It's the medullary osmotic gradient. Here we can see in one of the pictures here. Here, this is the juxtamedullary nephrons, where most of the concentrated urine production occurs there. You see the glomeruli, and here you see the kidney tubules, and the fluid around it is the extracellular fluid. And this is the osmolarity. And as we go deeper into the medulla, the osmolarity increases. See, the color of the water is getting darker. And here, this is where the reabsorption is occurring. So this change in osmolarity helps in regulating the reabsorption of water. However, most of the adjustment occurs here at the distal convoluted tubule and in the collecting duct, and we will see how that occurs. Okay, here, this is just a brief review so that you will remember that there are two kinds of nephrons, the cortical nephron and the juxtamedullary. Juxtamedullary are the deeper ones that are closer to the medulla, and their loop of Henle goes deeper into the medulla, and this is where the gradient occurs, as I showed you. So the antidiuretic hormone, when it's absent, it produces very dilute urine, and when it is high levels, it produces concentrated urine. And it is under the negative feedback, like many other feedback mechanisms in our body to maintain homeostasis. So the negative feedback with the antidiuretic hormone regulates the facultative water reabsorption in the distal convoluted tubule and the collecting duct. If you remember what is facultative water reabsorption, we know that the water is reabsorbed from the filtrate, and the water follows the sodium. Wherever sodium goes, water follows. Wherever chloride goes, water follows to keep the osmolarity. However, facultative, it doesn't follow the sodium. The water is reabsorbed by the decision of the antidiuretic hormone. So when the body is dehydrated or there is low water intake, then it means that the body is losing fluid, and the kidneys must conserve the water. So in this case, the nephrons will produce concentrated urine. How does that occur? In the hypothalamus, we do have osmoreceptors. These osmoreceptors will detect that the body's osmolarity, the fluid in the extracellular fluid and in the blood, the osmolarity is high because the water volume is low. So the osmoreceptors, when they detect that in the hypothalamus produces ADH, and the antidiuretic hormone, which is produced, stored in this posterior pituitary and is released. So here you have the stimulus increased in osmolarity, either by lack of fluid intake or by dehydration. So osmoreceptors detect it, and then the hypothalamus produces ADH, and then it is stored in the posterior pituitary, and the ADH is released from the pituitary, and it exerts its effects on the principal cells in the distal convoluted tubules and the collecting ducts. What this means is that the antidiuretic hormone produces some water channels, aquaporins, which will make the distal convoluted tubule cells and the collecting duct cells more permeable to water. So the water will get out from the distal convoluted tubule and from the distal convoluted and from the collecting duct, and will go back into the blood vessels. So what will happen here? When there is more water, the osmolarity will decrease. Here was the osmolarity increased. By negative feedback, the osmolarity will decrease and will go back into normal. So ADH produces these water pore channels called aquaporins in the principal cells, and the distal tubule will become very permeable to water, but not so permeable to sodium potassium. So the water will go by osmosis into the interstitial fluid, and the filtrate will become less concentrated. And from the interstitial fluid, here it will go into the blood, and the blood will become less diluted and will decrease the blood osmolarity. Okay, so here you see, I like this picture here where it shows how the ADH exerts its effect on the principal cells in the distal convoluted tubule and in the collecting ducts, and makes them more permeable to water, and the water will go out from the tubules and into the blood vessels and into the extracellular fluid, decreasing their osmolarity. Okay, so the bottom line here, with the formation of dilute and concentrated urine, or so what? Why do we care about it? Because the kidneys, along with antidiuretic hormone, they maintain the fluid volume and composition by producing more urine or producing less urine. They control volume by concentrating the urine, by when they are conserving kidneys and nephrons, when they conserve more water, they reduce the osmolarity. or when they excrete more water, they decrease osmolarity. It depends what is the situation of the body and what does the body need at that time. So the kidneys, along with the antidiuretic hormone, they control it. So if antidiuretic hormone is low or absent, dilute urine is produced. If antidiuretic hormone is high, then concentrated urine is produced. And then you need to know how antidiuretic hormone does that by negative feedback and also by binding and producing the aquaporins at the distal convoluted tubule and the collecting duct. Okay, so the urine which is produced, of course, is 95% water and 5% solids. And urinalysis analyzes the physical and chemical and microscopic properties of urine, and this is what we saw in the lab part at the urinalysis. So these solids, where do they come from? They are either filtered one or secreted at the end. In addition to urinalysis, which is very important diagnostic tool, there are two major blood tests that are performed to control or to diagnose or to measure if the kidneys are working normally. They are the blood urea nitrogen, BUN, and the serum creatinine. We know that the kidneys are the two kidneys are the most important organs in excreting nitrogenous wastes. So the nitrogenous wastes are the urea and the uric acid and the ammonia and the creatinine. They all are excreted by the urine. So if these are not excreted by the urine in normal amounts, then the nitrogenous wastes, they will accumulate in the body and produce their toxic effects. So that's why they measure the blood urea and the blood creatinine, which they increase in case of kidney dysfunction. So this table here is found in your lab section too. I'm going to ask you from here in the lab section, which I also placed the same table in the lab section. Okay, with the urinalysis, as we will see in the lab, or we saw in the lab, it tests physical and chemical and microscopic components in the urine. So these are some of the albumin is the major protein in the body, one of the major proteins in the body. So the urine should not have any albumin in it, except during pregnancy. So when they do urinalysis, they check albumin, they check the glucose. Urine shouldn't have glucose in it. If there is glucose, it means that the blood person's glucose level is more than 180 milligram per deciliter in the blood. There shouldn't be red blood cells in the urine, except very, very few sometimes. Ketone bodies should not be present except in very minimal amount. If there is uh, more ketone bodies than usual, it means that the person, uh, usually it happens in people either when they are starved or with diabetes. Of course, urine is very sterile. It shouldn't have any microbes unless there is infection. So the other parts of the components of the urine, you are requested to know them for the lab portion. So here we finished the urinary tract, and by now we know the waste management in the body, that there are, just to review, that there are other organs and tissues and that contributes to waste management. There is the buffer uh, waste management process um, that increases, uh, prevents the increase of acidity in body fluids. This is what we're going to study it when we study the electrolyte balance. And uh, the blood is the major um, tissue that transports waste. The liver also does a lot of recycling of wastes and toxins, and the extra fat and proteins, they are recycled in the liver. Lungs, they excrete the carbon dioxide along with water and heat. Sweat glands, they excrete urea, salt, water, um, and then the GI tract, they also excrete undigested food, waste, water, salt, etc. But the very important system is the urinary system. Gets rid of a lot of body waste materials, especially the nitrogenous wastes. So now let's go into some of the urinary diseases. Um, there are some terms that you need to know. If any inflammation in the kidney means pyelonephritis. If the urethra is infected or inflamed, urethritis. So if you add itis at the end of any word, um, it will indicate that there is some inflammation there. The bladder is called cystitis. If, and then if there is inflammation of the glomerulus, it's glomerulonephritis. And there is the nephrotic syndrome, um, and then the renal calculi, which is the stones in the liver, in the kidney, and then the bladder cancer, and the polycystic kidney disease, which is a genetic disorder, and the renal failure. So let's go into some of those diseases. So there is we all know about diabetes and how in diabetes there is increased thirst and increased urination and increased in blood glucose level. However, with diabetes insipidus, means false diabetes, there are the symptoms of polyuria, means increased in urine volume, polydipsia, increased in thirst. However, there is no increase in blood glucose level. The cause of diabetes insipidus, there are two main causes. Either the body doesn't produce enough antidiuretic hormone, and we know that because there is no antidiuretic hormone or the amount is less, then the kidneys are not able to concentrate urine, and the urine will be diluted. And when it is diluted and the volume is high, then the person is going to feel always thirsty. The nephrogenic diabetes insipidus is the kidneys, they don't respond to the antidiuretic hormone. They don't make the aquaporins in their distal convoluted tubules and the collecting ducts. So, since talking about diluted concentrated urine, let's talk about diuretics. Of course, diuretics, they are used to control hypertension and to control congestive heart failure because they reduce the body's volume and the body's blood pressure. By reducing the body's volume, the body's blood pressure decreases. So most of diuretics, they interfere with the reabsorption of sodium. So when the sodium is not reabsorbed, then water is not reabsorbed because, as we know, water follows sodium. When sodium is not reabsorbed, water is not reabsorbed. And the water, when it's not reabsorbed, it will stay in the tubule and will be excreted from the urine. So that's why diuretics makes the person to urinate a lot. And because the sodium also is not reabsorbed, so the blood osmosis will become less, and also the blood volume will decrease, and that will decrease the blood pressure. So there are two kinds of diuretics. One of them is the loop diuretics, that their action is at the nephron loop, at the thick ascending part of the nephron loop, and there are the thiazide diuretics that their action is at the distal convoluted tubule. There are natural diuretics too. Coffee is a natural diuretic. It inhibits sodium reabsorption. And also alcohol and beer, alcohol in the beer and wine, it is also diuretics because they inhibit secretion of antidiuretic hormone. Less antidiuretic hormone, then more urine production. The other common disease is the renal calculi or kidney stones. That occurs when there is excessive ingestion or of calcium, or low water intake, or sometimes if the urine is more alkaline or more acidic than normal. Sometimes the kidney stones are made of calcium salts or sometimes of uric acid salts, or it depends if the urine is alkaline or acidic, or if the person is on very high protein diet and genetically determined also in some cases that uric acid accumulates more in the blood and that is excreted in the urine, and it accumulates in the tubules and then it forms kidney stones. Sometimes the kidney stones are only calcium, sometimes they are only uric acid, sometimes they are mixed around the protein based. So there are different kinds of kidney stones depending on the state of metabolism of the individual. But no matter what they are, if they are very big, of course, they are treated by lithotripsy or breaking down the stones into tiny little pieces so that it will come out from the urine easily. Of course, if the person has uric acid, high uric acid, it is given some medications to prevent future buildup of kidney stones, or if it is with calcium, again there are some preventive measures to take, not to eat too much dairy or too much calcium. It depends on the analysis of the stone what happens, what kind of stone it is. Nephrotic syndrome is an autoimmune disease. In this case, the filtration membrane around the glomeruli is when you have the glomeruli, and around the glomeruli there is the filtration membrane. So this filtration membrane, made up of the podocytes and the endothelial cells of the capillaries, when they are distracted or destroyed in somehow, or so the permeability becomes is increased, means that the space between the filtration becomes larger, so it allows for larger molecules to be filtered too, not only small molecules. So proteins come out, red blood cells can come out, white blood cells can come out, which originally they weren't able to come out of the blood into the filtrate. So in this case, the person will lose a lot of proteins, will cause albuminuria, means the albumin will come out, and the person will have less protein in the body, less albumin in the body, and that will make the person to swell, especially around eyes and around ankles and feet. Urinary tract infection, or UTI, is a very common disease that affect the urinary system in different parts. It can affect just the urethra or just the bladder, or it can climb up and cause infection in the kidneys, what we call it pyelonephritis, which is a very serious condition with chills and fever and pain, and if it continues or if it's very severe, can damage the glomeruli of the kidneys. There are different microorganisms that cause urinary tract infections, and if it is bacterial, it is treated very easily by antibiotics. So there is the glomerulonephritis that is the result of a special allergic reaction to the strep toxin. So people get streptococcal bacteria, and if they are not treated, the toxins might affect the glomerulus of the kidney and cause inflammation there. We call it glomerulonephritis or Bright's disease. So in this case, what will happen is when the glomeruli are affected, they will be permanently damaged and will lead to acute or chronic kidney failure or renal failure. So what is renal failure? It means that the kidneys will stop filtration, or the filtration will be very slow, and that is the acute renal failure. So what will happen if there is less filtration or slow filtration? The urine output will decrease. So when does that happen? If there is hemorrhage, when there is decreased blood volume, it happens when there are kidney stones that are blocking the passages. It happens when there is cardiac output is decreased. When the cardiac output is decreased, again, there is not enough blood coming to the kidneys to be filtered. So these are all causes of acute renal failure. So what will happen in this case when there is not enough urine output? The metabolic wastes, especially the nitrogenous wastes, are going to accumulate in the body. And they check the BUN, they check the creatinine. If they are high, then they say, okay, this person probably is in renal failure, because of hemorrhage, or because of maybe sometimes dehydration, or it happens with people who have congestive heart failure, or their heart output is decreased. So there are many reasons that cause that, and it is of course checked by checking the urea BUN level and creatinine level in the blood. Chronic liver failure is if the person has a chronic disease that eventually will fail the kidneys, like if somebody has chronic glomerulonephritis. Okay, so we finished this chapter, chapter 26, and let me go over the beginning here. So from the beginning, of course, the very important part, the anatomic parts, I'm going to ask you more in the lab. However, you need to know about the nephron. You need to know the structure of the nephron. You need to know about the filtration membrane. And also you need to know about the types of nephrons, and also here about the glomerular filtration, and the very important slide in here about glomerular filtration, tubular reabsorption, and tubular secretion. These are the three steps through which the urine is formed. So you need to know this. I can't concentrate enough on this slide. And here is another one of that slide. So you need to know what is glomerular filtration, what affects the glomerular filtration, the factors that affect the glomerular filtration, the renal, neural, and hormonal regulations. And then don't forget to listen to these videos. Okay. And of course here the hormonal regulation, all the hormones involved in the tubular reabsorption and secretion. These tables are very important. And of course, as I said, there are always videos that I want you to listen to. Okay.